Inflammatory myofibroblastic tumors are soft tissue inflammatory pseudotumors rarely found in the intrathoracic cavity. IMTs may be benign, locally invasive, undergo malignant transformation, or metastasize. Patients may be asymptomatic or present with more nonspecific findings, including cough, hemoptysis, or pneumonia. A 33-year-old Hispanic female with medical history significant for severe persistent asthma, obesity, anxiety, and PCOS presented to the emergency department with dyspnea, productive cough, and wheezing of 1 month duration. Physical exam was notable for moderate respiratory distress with diffuse expiratory wheezing. She was afebrile, tachycardic, and tachypnic with oxygen saturation of 96% on room air. Preliminary laboratory workup demonstrated leukocytosis of 14.5 thousand, a positive mycoplasma IgM, and moderate elevation of IgE. No acute pathology was identified on chest X-ray. Treatment was initiated with bronchodilators, leukotriene receptor inhibitors, antihistamines, and IV steroids. Further review revealed an extensive history of recurrent admissions for similar symptoms, all of which were attributed to asthma exacerbations. Despite medical optimization, these symptoms persisted. Her hospital course was complicated by worsening respiratory distress and hemoptysis, prompting a pulmonary consultation. Non-contrasted CT of the chest revealed a 1.6 by 1.3 centimeter nodular structure suggestive of a mass or foreign object at the level of the carina. A flexible bronchoscopy was subsequently performed, revealing an endotracheal mass, occluding approximately 90% of the trachea. Mechanical dilation and resection of the tracheal lesion was achieved by way of rigid bronchoscopy. Pathology would later confirm the presence of a benign inflammatory myofibroblast tumor with immunohistochemical staining positive for ALK1. Inflammatory pseudotumors represent less than 1% of all lung tumors, with only about 11 reports in the literature of tracheobronchial IMT. They are composed of smooth muscle cells with prominent inflammatory infiltrate consisting of plasma cells. The ALK1 gene is expressed in almost half of the tumors, but the exact pathogenesis of these tumors still remain unclear. Surgical resection remains the most definitive and curative treatment for those with tracheal involvement. These tumors can cause severe respiratory distress in patients and lead to recurrent hospitalizations and unnecessary treatments, which is why early diagnosis is imperative. In adding to the limited body of literature addressing tracheobronchial IMTs, we hope to contribute to clinical diagnosis and treatment of this rare and insidious tumor.